Hey, welcome back to Neuroscience. Today we're going to go through the senses of hearing and the vestibular system. So the thresholds of hearing, it goes between like 20 decibels and 140 decibels. And the normal conversation level is about 60 decibels. So going through the path of sound, the auricle is going to direct the sound waves into the external auditory canal, and that's going to lead to the tympanic membrane, where the auditory vesicles will transmit and amplify the vibration through the little bones into the oval window. And then from the oval window, it's going to go into the organ of corti, where the vibrations are going to bend the hair cells. And then from there, it's going to cause the bipolar neurons to send the impulses down through the cochlear branch of cranial nerve number 8. So the organ of corti is made out of several different cells on a basilar membrane, and the predominant cell is the hair cells. So the bodies of the hair cells rest on the basilar membrane, and then the tips of the stereocilia are going to lie in the tectoral membrane. So basilar membrane is on the bottom, tectoral membrane is up top, and the upward mechanical displacement of the basilar membrane is going to cause the shearing force, so like when it's deflected up, and that displaces the stereocilia and the kinocilium laterally. And see, as you can see, here's the tectoral membrane. There, the stereocilia are going to come from there, and those will bend. That causes the hair cells to depolarize. And then the downwards displacement of the basilar membrane is going to cause a different kind of shearing force, and that hyperpolarizes the hair cell. It's going to cause the shearing force in the opposite direction, right? So why is that important? There's a couple theories, but the one I like the most is that the hair cells cannot depolarize all the time. There has to be a reset in order for the hair cells to respond to a different frequency. So if somebody is always speaking at like a very monotone tone, right? Without the hair cells kind of deflecting back to normal once the frequency of the sound wave has ended, there's no way that once this person continues talking and maybe they change their tone, the hair cells aren't going to be able to respond. So in a way, that could be why once you lose hair cells, when you age, people can't hear as well. That might be a component of hearing loss. So the vibrations from the bipolar ganglion are going to go to the inferior colliculus. Remember, the superior colliculus is going to be associated with vision. So then it goes to the medial geniculate body of the thalamus, to the primary auditory cortex. Remember, thalamus kind of is the relay center for all the senses. So everything goes through the thalamus: touch, hearing, vision, everything. Then the trapezoid bodies is where the axons decussate before going to the superior olivary nucleus. So here's the thalamus, and it goes to the auditory cortex, goes down, crosses over, goes to the superior olivary cortex, then all the way down to the cranial nerve number 8. So the first order sensory neuron is going to lie in the spiral ganglion, and those are your bipolar cells. The second order are going to be the cochlear nuclei to the corpus trapezoid and the superior olivary nucleus. Then the third order are going to go from the dorsal nucleus of the trapezoid body and the superior olive to the auditory cortex as the lateral lemniscus. The auditory cortex is also known as Herschel's gyrus, and that includes the areas 41 and 42. Primary auditory cortex lie in the temporal lobe. So, because the fibers go to both sides of the auditory cortex, complete deafness isn't really seen in unilateral lesions. Complete deafness occurs in the bilateral lesions. So there's two different types: conductive, which is the interruption of sound waves, and that can be caused due to like fluid accumulation, trauma, genetics, disease, some kind of medication, tumors, and osteosclerosis. Or sensory neural, which is the nerve deafness or perceptive deafness. And that can also be caused by medication, age, but also by acoustic neuromas, disease of the cochlear nerve, or central auditory path, and that can also be caused by trauma. Otitis media is very, very common in children, but they are the most common cause of meningitis, so you have to treat them very seriously. In children, they tend to like pull at their ear, and they're very irritable, and there's like a fever associated with it as well. So if you ever go into pediatrics, this is something that you really have to consider, because meningitis, bacterial meningitis, is treatable, but kills very, very quickly. As you can see here, this is a normal tympanic membrane, and this is an infected tympanic membrane. Look how it bulges out, and it's erythematous, and it looks horrible, really. This is one with some trauma, like minor trauma, but as you can see here, it's bleeding. Here, this is unfortunately a completely perforated eardrum due to this object being lodged in it. So the bacterium meningococcus doesn't cause otitis media, so something to consider. And otitis media is going to cause a conductive form of deafness. Okay, so autosclerosis is the neogenesis of the labyrinthine spongy bone. So new bone formation is going to fix the stapes, or it's going to calcify the oval window. This is the most common cause of progressive conduction deafness and occurs as we age. There is a surgery that we can do about it, so, not too bad, right? So here, the autosclerosis is like the incus right here is completely fused to the tympanic membrane. Sorry. So here the incus is normally connected to the stapes, and as you can see here, it's completely fused together. There's not even any differentiation. Okay, so an acoustic neuroma is usually a schwannoma, which is a overgrowth of the Schwann cells, and that's also called a neuroma. And those will push in and damage the cochlear nerve or the central auditory path, just due to compression of the structures. It is going to cause tinnitus and unilateral deafness. Okay, so the use of quinine or aspirin or streptomycin as a pregnant mother can cause congenital deafness in the child, along with the rubella infection, because that can cross the placental membrane along with the cytomegalovirus or syphilis. So that is pretty serious. There are some syndromes that are going to cause the congenital deafness. The most common one that we should know about is the Alport syndrome. The rest are super rare. And most of the times they are linked to some genes, but these are much harder to kind of like diagnose. Presbycusis is the hearing loss due to age, and it's a loss of hair cells, the elasticity of fiber, along with some cochlear damage. Most common cause of hearing loss, and it starts with high frequency loss. So these patients are going to be able to hear high-pitched tones. So when you're talking to a deaf patient, don't yell at them. You have to lower the pitch of your voice. So I personally have to do it quite a bit, because I do have a higher voice. So in really like extreme cases, I have to ask a man, especially a man with like a bass kind of voice, to talk to the patient because they are unable to hear the high frequency of my voice. Okay, so there are the testings that we use using a tuning fork. And the Weber test is going to test for the conduction of the conduction hearing. So you will strike the tuning fork on the palm of your hand, and once it has a nice strong vibration, you place the tuning fork right on top of the patient's head. You have to make contact with the end of the fork to their head. In a normal patient, there's going to be an equal loudness in both ears. But in a patient with unilateral conduction loss, the vibration is going to be stronger in the diseased ear. So this is going to be conduction loss. This is something involved with the bones, right? However, if there's a damage to the nerve in a unilateral partial nerve deafness, the vibration is going to be louder in the normal ear because of, remember, the decussation. So that's going to be normal in the undamaged side. So in the RIN test, there is going to be a tuning fork to test for the localized hearing loss by using air conduction. So you will strike the tuning forks on the palm of your hand, and once it's nice and, loud or strong, you are going to test both the air conduction and the bone conduction. So first, you're going to hold the tuning fork somewhat close to the patient's ear, about like 2 inches away, and then you are going to be able to, the patient is going to be able to hear the vibration in the air. Okay, so, and then you will strike the tuning fork on the palm of your hand again once the vibration has gone away, and then place the tuning fork right on the the mandibular process, like right behind the ear. So in a unilateral conduction loss, the patient isn't going to hear any vibration in the air. However, a patient with partial nerve deafness, they're going to be able to hear the vibration in the air in both ears, but they're not going to be able to the patient is going to be able to hear the vibration in the ear in both ears. Okay, so the vestibular system is going to be made out of 2 labyrinths. The first, this is the static labyrinth, is going to be made out of the utricle and the saccule of the vestibule. And those are responsible for detecting the position of the head in respect to gravity. So these are going to respond to acceleration or deceleration. The kinetic labyrinth is going to be made out of these semicircular canal, the anterior, the posterior, and this horizontal canal. And they are going to be responsible for coordinating the eye movement with the movement of the head. So when you turn your head, the eye should be able to either turn with the head or be able to fix onto an object. The maculae are in the utricle and the saccule, and they are a special epithelium made out of columnar supporting cells and hair cells. And they're embedded in a gelatinous mass that contain otoliths, which are made out of, the otoliths are little rocks, and they're made out of protein and calcium carbonate. So the gelatinous mass will move in response to gravity, and then inside the otoliths will also move, and then when they rest on the hair cells, they're going to bend the hair cells, and that was going to send an action potential. The crista ampullaris is a special epithelium, also similar to the macula, where the hair-like processes of the crista hair cells are going to be embedded in a gelatinous mass as well. This is going to form a little cup, which is creatively named the cupula or cupola. This, however, has no otoliths, so it doesn't respond to gravity. Instead, it responds to movement, especially quick movements. And the endolymph movement are going to bend the hair cells and initiate the action potential and the associated neurons of the vestibular nerve. The semicircular ducts are all at like right angles at each other, so they can accommodate every single plane to allow movement in all directions. The Peri lymph is similar to the extracellular fluid and plasma and CSF. It has a lot of potassium, and it surrounds the membranous labyrinth, and it communicates with the subarachnoid space via the cochlear aqueduct. So if there's a problem with like too much CSF, it can like it can like backflow into the cochlear aqueduct and cause problems with the vestibular system and the sense of balance. The endolymph is similar to intracellular fluid, so there's a lot of like there's a lot of sodium and chlorine. They are secreted by the stria vascularis of the cochlear, and the movement of the endolymph will go in the opposite path of the head movement. So, as you can see here, it kind of goes into like a spiral path. Okay, so the tilting of the head changes the angle between the otolith organs and the directions of the force of gravity. Why is that important? Because different degrees of tension of the hair cell stereocilia is going to depend on that kind of orientation. The linear acceleration is going to displace the otolith and excite the hair cells in the macula. It's going to provide a sense of euphoria and vertigo. So this is what you feel when you're on a roller coaster ride. So the first order of the sensory neuron is going to form the vestibular ganglion, and that is going to lie in the fundus of the internal auditory meatus. The peripheral processes of these cells end on the hair cells of the macula and on the hair cells of the crista of the semicircular duct. The central process of the bipolar cells will form the vestibular nerve, and that will relay into the floccular nodular lobe of the cerebellum. So all of this is going to be responsible for your sense of balance, your sense of proprioception in space. Your your second order sensory neuron is going to go from the floccular nodular lobe to the inferior cerebellar peduncle. The motor neurons or nuclei of cranial nerves 3, 4, and 5 are going to go through the medial longitudinal fascicle, and the anterior horn cells are going to provide information to the skeletal muscle to maintain upright posture. The vestibular nuclei is going to go to the posteroventral nuclei of the thalamus for the sense of balance. So, like I said before, all your senses go through the thalamus to be relayed and interpreted. Lastly, the third order neurons are going to go from the thalamus to the postcentral gyrus, which is your motor cortex. And the vestibulo-thalamocortical connection, so between the vestibular nuclei, the thalamus, and the cortical part of your cerebellum is going to be responsible for your sense of balance. So it's pretty involved. Okay, so the problems with the vestibular nuclei, proprioceptive receptors, or visual receptor can cause a truncal ataxia. So this is going to be imbalance in your core. This person is going to wobble around like from the upper body, and they're also going to have a staggering gait as a result. This can also cause nystagmus and vertigo. But this vertigo may not be a permanent thing, right? So the vertigo can, of course, be caused by a lesion in any of the above, but it can also be caused by a displacement of the otoliths after a particularly gnarly roller coaster ride. So you know that feeling where you are pretty dizzy even after the ride has ended for about a couple minutes, in some people, a couple seconds in others. It's because your otoliths are still trying to like re-establish their place. They're trying to come back to their original position. That's why you feel that sense of like vertigo, spinning, and dizziness. Okay, the vestibular ocular reflex is responsible for keeping the image in the center of the retina. So this is going to be responsible for your central vision. It's a 3-neuron arc. The ocular motor nuclei, vestibular nuclei, and the vestibular ganglion is all involved. The primary afferent fibers are going to go and relate to the vestibular nuclei, and then from there it's going to send an axon to the nuclei of the extraocular muscle. And all of that allows the abduction and the adduction by the stimulation of the abducen and the ocular motor nuclei. So this is going to also inhibit the antagonist muscle. So if it stimulates the abducen, it's going to relax the other muscles in order for coordination of the eyes. So we test the vestibular ocular reflex in conscious or unconscious patients by stimulating the kinetic labyrinth and using cold water. So when you put cold water in a patient's ear, automatically it's going to go to on the opposite side. So, and then once you put warm water in the patient's ear, normally it should go to the same side. So that will be that's going to be explained in the next couple slides. Sorry. The oculocephalic reflex is going to be responsible for the rapid head movement in any plane, and in a normal patient, the eyes will move conjugate in the opposite direction of the head movement. So if you turn left, your eyes will go to the right. In a doll's head reflex, the eye movements are absent or abnormal when a lesion of the vestibular nuclei or the medial lemniscus fasciculi is present. So they're going to be fixed to a side. So even like if you turn your head to the right, eyes are going to be to the right. If you turn your head to the left, it's also going to stay on the right. The vestibular nystagmus is going to be the darting movement after looking to the side. So if I tell my patient to look to the left, there's a darting movement to the right as they continue looking to the left. And that's all due to the stimulation of the hair cells in the semicircular ducts on rotation. The post-rotational nystagmus is when a patient is spun after a couple seconds, and in a normal patient, there is horizontal nystagmus opposite from the direction of rotation. So if I spin them clockwise, the eyes are going to go counterclockwise. That doesn't make any sense. Let me make it a little bit more simpler. If I turn my patient to the left, the eyes are going to go to the right. And normally they're going to fall in the direction of the rotation. So if I turn them to the left, they're going to fall to the left while the eyes dart to the right. And there is going to be a sensation of vertigo on the right side. This is not really done too much in a clinical setting because as in the falling kind of aspect of this test, it can be kind of dangerous. Instead, we use the caloric nystagmus. So I kind of explained it before. When you put heated or cold water into the ear, you irrigate the external auditory canal, and that is going to cause like it's going to force the stimulation of this semicircular canal and cause the nystagmus. We remember that by cows. So you put cold water in one ear, and the patient is going to look to the opposite side, while in warm, it's going to look to the same. Warm water will increase the rate of firing in the vestibular afferent nerve, and it mimics the head turning to the ipsilateral side. So the eyes will turn to the contralateral ear. Cold water is going to cause the endolymph to fall in the semicircular canal, and that's going to decrease the rate of the vestibular afferent firing. So it's going to mimic head turning to the contralateral side, and eyes are going to turn to the ipsilateral ear. So it's going to be going to the opposite. Okay, so intranuclear ophthalmoplegia is what we're testing using the irrigation technique, or the caloric irrigation technique. And that's where there's a problem in controlling the conjugate eye movement due to some kind of damage to the medial longitudinal fasciculus. And that is going to that's going to cause a lack of coordination in eye movements. There's going to be a problem in adduction. And then the patients are going to complain of horizontal diplopia because they're not able to kind of fix the vision and coordinate the visual information. So they're going to have double vision, and they're not going to be able to track fast moving options. So as you can see here, if I tell the patient to look straight ahead, it's normal. And let's say that there's a lesion at the right. So if you look to the right, it's going to be normal. Abduction is normal. But if I say look to the left, there's going to be a problem looking to the left. However, the patient is going to be able to cross their eyes. So since there's a lesion on the right, MLF, if you use the caloric method, and I put the water in this patient's right ear, if I put the cold water in the patient's right ear, this eye is going to be able to go contralaterally, but this eye is not. Okay, so in the vestibular problems is usually motion sickness or tinnitus. So tinnitus can be caused to damage, physical damage to the eardrum, or medication. There's a whole list of them that can cause tinnitus as an adverse side effect. Vertigo is going to be characterized by a spinning sensation. So if you ask your patient if they have vertigo or not, you can't ask them if they feel dizzy. You have to ask specifically if the room is spinning. So that can be caused by lesions in the labyrinth or the vestibular division of cranial nerve number 8, or some kind of brainstem vestibular nuclei lesion. Another cause can be Meniere's disease, where there's an increase in the endolymph fluid pressure due to maybe some kind of CSF problem or production problem. Like I said before, they're connected by the cochlear aqueduct, so overproduction of CSF can back it up in the aqueduct and put pressure on the endolymph. So Meniere's disease is characterized by vertigo, tinnitus, hearing loss, conduction, hearing loss, fullness in the ear, and there's going to be horizontal nystagmus during attack. Luckily or unluckily, this is a kind of transient, so there are attacks that come and go. So in a patient with vertigo, you want to do a couple maneuvers. In the office, you can do something called the Epley maneuver, where you will position the patient's head yourself. So you turn them to either side, and then the affected ear, you're going to turn it further, so the ear is going to be parallel to the floor. And the half somersault method is something that you do yourself. So first you look up at the ceiling, and then place your head in the somersault position, and then turn your head to one side, raise your head quickly, and then raise your neck up. And you do this to the other side as well. Okay, so that's it for now. Thank you for your attention, and good luck studying.